Hi, good morning, everyone. So we are going to have a wonderful session here, though it's a very small 45-minute session, but we have three beautiful talks by the eminent speakers. The session is on the new horizon in glaucoma management. And the first speaker is Dr. Sirisha Senthil. There is no need to introduce Dr. Sirisha. Everyone knows she is the head of glaucoma services at LV Prasad Eye Institute, Hyderabad. So Dr. Sirisha, it's all yours. Start with what's new in the surgical management.
Thank you, Dr. Vyas, for the kind introduction. I'll just share my screen. Is my screen visible?
No, ma'am. Do it again. Yes.
Is it fine now? Yeah.
Yeah.
Thank you. So the treatment paradigm for glaucoma is medical management, surgery, and sometimes if these two do not work, we move on to surgeries. So I think what is very important is close to about 80 to 90% of the patients, we treat them medically. And when we decide to do a surgery, it really needs a pressure reduction, which is a significant pressure reduction. Mitomycin C has definitely improved the success rates of trabeculectomy, because I think trabeculectomy is the only unconventional surgery in the body where we want to create a wound and don't want it to heal. So because the natural tendency is to heal, we try and use several medications to prevent the healing, and in the process end up having a lot of complications. So one needs to be very, very clear about using the medication, especially the mitomycin C, and also not end up having complications. The implants are definitely used for refractory glaucomas, but we know it's a huge hardware that is sitting in the eye with its imminent complications. So if one of us have been doing this for a long time, we know that at some point in their lifetime, be it 10 years, 15 years, 20 years down the line, there is some problem or the other that occurs because of a huge hardware that is sitting inside the eye. So now we are wondering, what are the safe surgical options? So many times, in fact, it's not uncommon these days when a patient comes to us and asks us. In fact, I think about four years ago, there was a patient who came to me and asked me that despite having a very difficult glaucoma, pseudoexfoliation glaucoma progressing, I don't want trabeculectomy, I don't want a tube, I want you to do something that is a non-penetrating or a minimally invasive glaucoma surgery, because I don't want to have a complication. So that is how demanding it is these days. And even we are very worried about performing a surgery where we're worried of the complications that we may have. So this is where the role of MIGS, a micro-invasive glaucoma surgery, plays a role. So they're not minimally invasive, they are invasive, but they are possibly slightly less invasive. So what we try to do with these procedures is to improve the physiological aqueous pathway, no bleb-related problems apparently, and no hypotony in majority of these cases. Advantage is that it can be combined with cataract surgery, but we do not have too much of an intraocular pressure control the way we get with trabeculectomy. There is a moderate intraocular pressure control with these devices. So they're basically ab externo and ab interno type of devices, where when you say ab interno, it is using the Schlem's canal, the trabecular meshwork Schlem's canal pathway, the collector channel that goes beyond. So basically you're trying to improve the drainage through the conventional pathway by removing the existing resistance, if at all, the trabecular meshwork and the inner wall of the Schlem's canal. The other type of procedures are the subconjunctival procedures, which are the Zen and the infocus, and suprachoroidal procedures, where you are using a different mechanism to try and bring down the intraocular pressure. What is very important for us to note is the intraocular pressure achieved by all these procedures, except the subconjunctival devices, IOP reduction has something called a floor effect. You know, you don't use this term typically in a surgery, but what I mean by that is that intraocular pressure reduction cannot go less than the episcleral venous pressure. So it has some limitation there, and it depends upon the distal outflow capacity of the collector channels. Multiple MIGs are available, starting from iStent, iStent Inject, iStent Supra, CyPass, the Aquisys system, and the newer ones that are available nowadays, which is the in-focus implant. So looking at the trends of glaucoma surgery in the US, you see that the filtration procedures, typically the trabeculectomy is coming down, and many people are preferring to use the non-invasive or the mixed procedures much more commonly along with cataract surgery. A few things that are very important for us when we start doing mix is that one needs to be very comfortable doing a direct gonioscopy during the surgery. So the gonioscopic visualization of the angle is very, very important. So your surgical success depends upon how well you are able to see the structures and how well you are able to do the procedure. One important tip I would like to give for people who want to start mix is to identify the trabecular meshwork and also identify the Schlemm's canal. So sometimes blood in Schlemm's canals gives you an indication that this is the area where you have to really start your procedure. Anatomically, there are the collector channels are maximally placed in the infronasal and in the nasal location, basically inferior nasal and superior nasal areas. So that is why most mixed procedures try and target these locations. The intracanalicular devices like iStent, I don't have personally experience with this because of the expense of the device, and they're not available in India. So there are multiple generations that are available. And the people use more than 2 iStents in the same eye in opposite directions so that they target the 2 areas of Schlemm's canal drainage. The other one that is available is a Schlemm's canal scaffold called Hydrus. This is again an important device that is part of it is placed in the AC and part of it in the Schlemm's canal. It helps to widen the Schlemm's canal. Again, this is not available to us, but it's supposed to not just enlarge the Schlemm's canal, but also try to have a larger device in the Schlemm's canal. The most promising ones, if you ask me, what is the role of MIGS in India? I think that is what I am looking at, and that is what I would like our viewers and delegates to keep a watch on. So what is available to us and what can be performed with us? So they are the Schlemm's canal procedures. I think currently what we are doing is GAT and KDB. These are 2 procedures that are available and we are able to perform them. Omni or a 360-degree ab internal trabeculotomy is again the same like your suture GAT, but you're using a device with a preloaded suture there, but that is again expensive. This is not something that we routinely perform. Ab internal trabeculotomy or the trabectome is also another procedure that again it involves cost and expenditure. So these are also good, and a few centers in India are also performing them. So my slides are stuck. Can somebody help? I'm not able to move the slides.
Please click on the center.
All coordinator, please look into that.
Yeah, see, I'm not able to see the pointer also.
Can you click, ma'am, on your laptop?
Yes.
Can you click on the laptop through your mouse or something? Just try moving.
Yeah, I am trying to. I'm trying to move on the pad as well as the...
Ma'am, even your video seems to be stuck. Maybe there's some network glitch that has happened.
Sirisha, on your left side bottom, there are the buttons. You just try there. You're not able to move the mouse also.
Yeah.
Okay.
Just as
you will have to escape and restart or relog in. Do that.
That would help.
Yeah, that would help. And maybe, sir, we can go to the next one and Sirisha can finish after that.
Yeah.
Sure. Yes, sir.
So you can move to the next one. I will relog it again.
Do it now, Sirisha.
Sirisha, it will take just a few seconds.
Just stop share and start share again.
Do it again.
Your sharing has been stopped, ma'am. If you can do it again.
No, so the thing is, I don't see the mouse there. So I'm not able to move at all. I can't go and click on any button there. So
That's ma'am, sir, I think we'll have to go to the next one because she'll take time.
Okay. Sirisha, are you trying?
I think, sir, she has logged out and she will re-log in some time. I'll
Okay,
call
so
her
by the
and
mean,
try and understand the thing.
yeah. Please do that. So by the meantime, we will move on, and lots of exciting things are happening in the medical management of glaucoma. So let us hear it out from Mayuri that what are the advances in the medical management of glaucoma. Dr. Mayuri is currently a treasurer of Glaucoma Society of India, and she is a renowned glaucoma expert practicing in Ahmedabad. Dr. Mayuri, it's all yours.
Thank you, Pratik. Good morning, everyone. I will be talking on the advances that are there and what is their new thing in the market, as well as what is going to come up. And there are so many innovations happening in the medical management of ophthalmology. And after the use of intravitreal implants in the retina, we are also excited whether we can have anything brewing for us in the glaucoma. So what are the new therapies on the block? I will going to highlight first what is new in the market and what is going to come up. So after the waiting of 20 years, now we have two new class of drugs, and both are FDA approved in USA. In India, we have ripasudil and netasudil, and the second one is going to be there in the near future. And both has a novel approach in the intraocular pressure reduction. The ROX inhibitor, two molecules are available, ripasudil and netasudil. They reduce the cellular stiffness, plus they have norepinephrine transport inhibitor. So they facilitate trabecular as well as uvascular outflow. The dosing is once daily, and latanoprost bunod is a 0.02 24%, a very small amount, enhances the uvascular outflow. Now, bunod is a nitric oxide and it dilates the blood vessel, thereby improve the circulation. Now, ROX inhibitor, 3 molecules are there, only 2 are in the market, and the ripasudil is decreasing the resistance to the TM outflow pathway. Reduction of IOP is seen about 3.7 millimeter of mercury, and twice a day is the dosing, while netasudil is decreasing the resistance of TM as well as reduces the aqueous production. And the IOP reduction is 5.5 millimeter of mercury. Now, it improves the trabecular meshwork outflow, also reduce the aqueous production, and it reduces the episcleral venous pressure, which essentially sets the floor on how low the eye pressure can go. This is very important. So even with a low eye pressure glaucoma, you can achieve the reduction of intraocular pressure. So it is independent of the baseline IOP. That's the benefit to this class. And again, it is giving neuroprotection of the optic nerve, improvement of the blood flow to the eye, and there is a reduction of oxidative damage to the trabecular meshwork. How well does it work? It seems to work about as well as either timolol or latanoprost. So many studies are there for the superiority or inferiority trials, and baseline IOP of all those patients was lower than 25 millimeter of mercury. However, one should remember that it is not a fast-acting drug, as it can take up even up to 6 weeks to have its full effect, IOP lowering effect. So don't be in hurry to add one more medication when you have put patient on this drug. Wait for at least month or 1.5 months. It has a potential for treating the normal tension glaucoma. Unlike other glaucoma medication, the IOP lowering effect of netasudil does not depend on the initial IOP. That is what I said in the beginning. So whatever is the intraocular pressure, as it has an effect on the lowering of the episcleral venous pressure, it can lower the IOP by 4 to 6 millimeter of mercury regardless of the initial IOP. Now, the chronic use of steroid can often lead to elevation of the intraocular pressure. The steroid response appears to be at least partially induced by the rheokinase activation at the trabecular meshwork. Thus, it makes sense that a ROC inhibitor could potentially prevent or limit the steroid-related elevation of intraocular pressure. Now, what are the side effects? The conjunctival hyperemia is the most common side effect that I have seen in my patients. About 40 to 50% of the patients, they do complain. And this hyperemia is due to relaxation of the blood vessel. And how to minimize this side effect? We can't do anything but ask patient to use this medication at night time. So that will be little better compared to the putting it in a daytime. Now, conjunctival pateal small hemorrhages at the limbus are also seen in some of the patients. It gives conjunctival stinging sensation upon instillation, eye irritation and discomfort in many of the patients, and blurring of the vision usually observed by this patient is usually temporary for a few minutes. And headache is also another side effect that has been noticed. Now, corneal side effects, the versillata, fine pigment deposits on the, as shown in this picture, on the corneal surface is also one of the side effects of this medication, but it will not affect the vision and are generally only visible under the microscope slit lamp. So vertex keratopathy is reversible with the discontinuation of this drug. And I have put up a question mark because there is a paper which has shown that it might alter the sclera, as PG analog sometimes do alter the sclera. Same thing is being said about this drug. And there is a case report about the associated epithelial keratopathy by this medication or the reticular epithelial edema in the edematous cornea. So I will not suggest you to use this medication, and these all are reversible changes. The second drug is latanoprost bunod. Versillata is the trade name. It releases the nitric oxide. Once a daily dose, it's a prostaglandin analog that is metabolized into two moiety. One component is latanoprost, second is bunod. And latanoprost enhances the uvascular outflow, while because it activates, relax the cellular relaxation in the trabecular meshwork, there is a widening of the intracellular spaces in that area. That's how it improves the outflow facility. And it also, nitric acid dilates the blood vessels, so improves the circulation. So the efficacy is about 32%, 1.2 millimeter of mercury additional to the IOP layering compared to the latanoprost alone. And it is effective both day and night. It is safe, just like any PG analog, but irritation, eyelashes, changes, and hyperemia is that because of the PGs. So I will put this drug as a first line of option in all patients of mine for open angle glaucoma where PGs are not contraindicated. Now with these two drugs, it is possible to have some effect on the neuroprotection. Maybe they have a role in the neuronal tension glaucoma. Now the combination of the netosudil and latanoprost is also available in Western world. This is also once a daily, and it also improves the adherence issue by using this as a combination. Now we know that glaucoma is a chronic disease, also involve a lot of expenditure in the investigations and drugs, and drug non-compliance is an issue with this disease. So we end up with the invasive surgery, which has its own side effects and complications. So we have to bridge the gap between the two. So how can we do so? So many drug delivery system, new systems are been shown here and are being practiced nowadays. So to major approach to overcome this challenge is apply devices to the ocular surface like contact lens or rings or intracannular implants, or one can inject intracamerally some implants. This is a very nice sentence that I have come up with. Patient only uses 72% of their topical glaucoma medication, but the estimate in the real world is closer to 50%. So a lot of non-compliances are there. So we need something which can deliver the best for us to improve the compliance. So sustained release option is one, subconjunctival delivery of the biodegradable polymer microparticles formulation are available. This patient photograph I have taken from the net. Here you can see the deposition of this, of the travoprost. Secondly, bimetoprost sustained release implant is been, they have completed phase 3 trials. The Allergan is doing that, and it is to be kept in, injected intracamerally, and 6 to 8 millimeter of mercury reduction is seen for the 6 months. So these are the internal platforms which are under the control of the doctor. Same thing, travoprost implants are also extended release biodegradable polymer implants are also available, which reduces the intraocular pressure by 35% over 8 months. So a few words on the Durasist, which is bimetoprost implant of 10 microgram. It comes preloaded and has to be injected intracamerally. And they have suggested 3 injections. The study are being done. Artemis study 1, part 1 and 2, and phase 3 trial results were published in 2020. The only word of caution here is they are also looking at the endothelial cell density count, and the cystoid macular edema sometimes is observed. So one has to be very careful when we use it in the pseudophakic or aphakic eye. Another new drug delivery system is microdrops. It's a Ionovia technique, uses variation on high resolution inject printer technology that allows patient to self-administer small doses of drug to the eye. And so there is a decrease in the side effect and increase in the safety profile. The punctal plugs are also there, but the disadvantage is sometimes it may fall out and patient may not be knowing. So the injected devices, the disadvantages, it requires the injections done in the clinic and carries the risk of the infections. These are various, this tree showing you the external platforms. So punctum plugs, topical ophthalmic drug delivery devices stored, they say, they are placed under the upper lid and works for the 90 days. And the rings are also available, and the contact lenses are also available. This is how the ring is preservative-free ocular ring is of 1 millimeter thickness, and it is to be placed underneath the lid in the fornices, deep into the fornices. And bimetoprost is put in the center of this silicon matrix. So another platform is the periocular injections. Durasert latanoprost injections are there. And the latanoprost, large unilamellar vesicles are also derived from the liposomes. And this releases the drug for 50 days. And lastly, the ophthalmic micropumps are also designed, which has to be placed over the sclera subconjunctivally. These are wireless, programmable, refillable, and dispensing nanoliter size doses. So it lasts up to 12 months, and then you can fill it and re-implant it over the sclera.
Sorry to interrupt, ma'am, but request you to wrap up in the next 1 minute.
These are 2 slides only. So nanoparticles exhibits high encapsulation efficiency, drug loading capacity, and stable control release efficiency. So the new study has been come up, which has they have shown the co-delivery of brinzolamide and the miRNA 124 by the biodegradable nanoparticles as a strategy for the glaucoma. So what we will get out of this, it has a wide potential for the social and economical benefit, and it will give not only the reduction of the intraocular pressure, but we might have some effect on the neuroprotection aspect also. So the challenges are many. We have seen pilocarpine sustained release occlusions in long back in my early residency days, but they have also had a problem, the dislodgement and backpacking of the drug and soluble issue. So still we have not reached the target. So many new things are still, options are available in the lab. I can't just say them all in this platform, but we will see a new era in the glaucoma medical management. Thank you.
Thank you, Dr. Mayuri, for very comprehensive talk. Now, Sirisha, are you ready?
Yes, Dr. Pradeep.
Yes, please go ahead.
It's not coming up. Sirisha, do it again. Yes, yes, it is there.
Yeah, sorry for that interruption. So Kahook dual blade goniotomy is another one that we are performing. So we use a dual blade to go intraocularly and try and open up the area of the trabecular meshwork. I'll just show a short video. So this can be done either prior to performing a phacoemulsification or at the end of the procedure. I prefer to do it at the end of the procedure because that microbleed sometimes can obscure the view and I don't want it to disrupt when I'm doing the cataract surgery. So at the end of the procedure, if you're doing a temporal clear corneal, it's quite easy. So you can go in through the same incision, use a Cahook dual blade, and through a Schwann-Jacob direct gonio lens. If you see, the lens is placed just over the cornea without any corneal folds. So blade is inserted into the area of the Schlemm's canal. You can see regurgitation of blood there. You can use the blood or the tip to actually go and open up the area of the Schlemm's canal on both the sides. So that strip that you see is coming out that can actually be peeled off with the help of microforceps, or sometimes even the IA cannula will help it to peel away. So generally we tend to do about 180 to 200 degree, and at the end of the surgery you try and close it up. So these are the post-operative gonio pictures. You can see a beautiful ridge here. So this white ridge tells you that that is the wall of the sclera that you are able to visualize. We do see microhyphema in these patients, but majority of them, they resolve in a couple of days. Most of them have reduction in use of anti-glaucoma medications post-operatively, and we have not seen any serious complications in these patients. Another one that is commonly performed is suture GAT, and this is my current favorite. So what I use is a 50 Prolene with the help of an umbrella tip that is again used to, along with the cataract surgery, or as an independent procedure. So at the end of the cataract surgery, this was a gentleman for whom the primary surgery had failed. So previous trap had failed, and he was on 4 anti-glaucoma medications. So you can actually see incision of the trabecular meshwork using a 50 Prolene suture with the help of a Grishaber microforceps. You try and insert the suture into the Schlemm's canal. And like I said, this patient superiorly had a failed trap. So I did a 270-degree GAT. So you go through it in the area where the superior trabeculotomy, the trabeculectomy ostium was there, it got stuck in that place. My intention was to cover up as much as possible. So this gentleman, now I think close to about 6 months follow-up, is 14 millimeters of mercury pressure off all topical anti-glaucoma medications. So this can also be done when a failed other procedures, like let's say a failed AGV, but open angles. Instead of doing one more conjunctival procedure, or you don't have a conjunctiva available, we can do it as a second procedure also. I borrowed this video from a colleague of mine. So again, the procedure is the same. So you don't have to really worry about doing a second implant, but I think this is really revolutionized, for me at least, the way we look at secondary open angle glaucomas. This is a video that I wanted to share. So this was a patient who had a uveitic glaucoma. They are very good candidates for GAT. You see the blood in the Schlemm's canal. So much of reflux of blood in the Schlemm's canal, it becomes extremely difficult for you to perform a GAT or any procedure. So I decided to just go ahead and do a goniotomy. That means I visualized the area of the trabecular meshwork and went and did a goniotomy the way we do it in a child for up close to about 200 degrees. And this patient now on one single anti-glaucoma medication, the pressures are well controlled. So we can do a lot of procedures, and I think we have underutilized the utility of these gonio-based procedures. The others, like, we don't have them, but I'm just for completion's sake showing them. Zell implant as well as the InFocus implant. This is one implant which is showing a great promise, but we would be very happy if Santon, I think, is trying to get this implant. If we get it, it'll be very nice. So again, it's a very tiny microshunt, but this uses a subconjunctival drainage process. So how do the IOP control work? So if you look at these, the subconjunctival procedures like the InFocus and Zen has the maximum intraocular pressure control compared to the Schlemm's canal procedures. If you remember the floor effect that I told you, that is what plays a difference here. Same way, number of anti-glaucoma medications in the post-operative period significantly come down. Our intention should not be no anti-glaucoma medication, but to decrease the anti-glaucoma medications. This is a beautiful chart, although it's a busy chart showing the IOP reduction. So sometimes you can have an IOP reduction as minimal as 10% to as high as 55 to 60%. So that is the beauty of these procedures. Individualize it and use it to your patient. But if you have an angle closure disease, progressive glaucoma, uncontrolled intraocular pressure, where patients are allergic to anti-glaucoma medication, so these are indications where I would not even think about doing a mix. I would myself go with the conventional procedures. But otherwise, I think mix have a huge role to play, and I'm extremely happy that we are able to do these procedures which are less expensive today. So with the Proline GAT, it hardly takes you about maybe 500 to 1,000 rupees extra, which is even cheaper than any other procedure that is available in the market today. So they are safe, decreases the number of anti-glaucoma medications. You can avoid conjunctival complications. And remember, IOP can be achieved only in the mid-teens, and hypotony related complications are far less or almost absent. So it is very interesting. New ones are in progress, and I think this is an encouraging field that we should be looking forward to. So thank you.
Dr. Vyas, you are on mute.
So thank you, Sirisha, for a wonderful talk, and I'm sure that we are going to have lots of discussion on that at the end of this session. And before that, I would like to invite Dr. Manoj Mathur. Dr. Manoj is a leading glaucoma expert practicing in Hyderabad. He would be talking on the using technology for better outcomes. Dr. Manoj.
Yeah. Good morning, everybody. So today I shall be speaking a bit about using technology for better outcomes in glaucoma management. So it is not very uncommon that you prescribe medication for the patients and you ask them to come after 3 months. The patient finishes the first bottle and then stops using the medication. Then if you ask the patient to come for 3 months, the patient comes after 4 months. Uses for the specified follow-up time, that is 3 months, and then for the last 1 month, she doesn't take the medicine. Sometimes the patients admit to discontinuation and await further orders. That means they say that I could not come after 3 months. I finished the bottle 1 week back. I just wanted to have a reconsultation, and I then start the medication again. Then sometimes the patient stops medication in between and restarts just a week before the scheduled appointment due to compliance factors. So how to go about it? So this is an app that is developed. What is Beat Invisible Beat Glaucoma app? Beat Glaucoma app is an exclusive personalized mobile app for patients and web-based platforms for doctors. And the objective of this app is to overcome the clinical challenges in the medical management of glaucoma and to simplify the disease management at doctor and patient level. So how is the disease management happens from the doctor's perspective and from the patient's perspective? From the patient's perspective, the patient has access to the mobile app. And from the doctor's perspective, the doctor has a web-based platform for this purpose. So from the doctor, what are the challenges that he faces? The challenges are for adherence of therapy. One is the dosage history. The patient is not very clear as to say that the patient is using the medication properly, and there is no concrete data to evaluate how regularly the patients are taking medicine. If you ask the patient, are you using the medicine? The patient says, I use the medicine. There lies all the difference. The verbal communication is the key. The patient database will minimize this verbal communication if the patient is using this app. And the irregular follow-up visits, like in our subset of patients, it is always important to need to remind the patients about the follow-up visits to have a proper schedule. And from the patient's perspective, what are the challenges that the patient faces? The patient faces, the first and foremost challenge that we encounter from the patient side is forgetfulness. The patient is that forgetfulness is cited as one of the major reasons for the barrier of adherence. The lack of information. The patient is not aware about the disease management. The patient is not too much aware about the pathogenesis of glaucoma because there is no magic result like in cataract surgery. Patient sees that I was what I am today. So the importance of medication and the economic barrier in most of the patients that the patient tend to not follow your medication as advised. Now, with this app, what are the benefits to the doctors? This app and the web-based system provides a personalized mobile application for the patient, the web-based platform to access, update and maintain patient database. The doctor, you can upload the IOP readings, the OCT, HBF, and OD and Gonio images can be uploaded. You can have a complete information about that patient. You can upload in your web-based system, and that is automatically it is automatically seen in the patient's mobile app. You can track the patients for dosage history, and it is excellent patient engagement and promotion tool. The benefits to the patients. The patient gets regular dosage and follow-up visit reminders with easy access to consulting doctors. The disease awareness and management information is incorporated in this app, and the glaucoma vision simulator. The patient goes through this vision simulator. The patient understands the importance of the disease pathogenesis of glaucoma, and the patient has less tendency to not comply with your medication as advised. And the frequently asked questions and patient education 2 videos on glaucoma are incorporated in this app. From the patient's view, the patient has access to Beat Glaucoma, the app. What does it offer? It offers daily medicine and dosage reminders. It has patient education material. It has a vision simulator. It gives the patient follow-up visit reminders. There is an IOP tracker inbuilt in this app, and this is a customized app. And it is available on iOS platform as well as Android platform. And from the doctor's perspective, it is a web-based system. It is a one-time easy registration for the doctor. It has quick access to the patient and medical profile and database. Patient's dosage histories can be uploaded, and the treatment upload from the web portal, which is synchronized with the patient's mobile app. So just let's have a small demo.
Follow-up visits. That's it. Medicine reminder. Patients can mark the medicine reminder as taken list or snooze. Patients can upload. Your personalized web page of glaucoma.
So this is about the app and the web-based system for the doctors. It promises to be a good tool for the single practitioners and eye centers, but remains to be seen how this app features can be incorporated in the already existing EMR systems of institutions. With this, I conclude my talk. Thank you.
Thank you, Dr. Manoj. Though the sound was not very clear in your video, but because it was subtitled, so yes, we could gather most of the information. Thank you very much. It was pretty interesting. So I think we have around 5 to 6 minutes for discussion. So let us start with Dr. Sirisha. Dr. Sirisha, you gave a wonderful talk, and just tell me one thing that what is the first and foremost indication for you for the MIGS about the trabeculectomy when you decide that you would not do the trabeculectomy in this patient and you will do the MIGS?
Yeah, so it started off when I wanted to actually operate a uveitic glaucoma patient with open angles and strong steroid responder, as ankylosing spondylitis, has multiple systemic problems, and coming back to the hospital was a problem. His disc was healthy. Pressures in the 50s, not coming down at all. So I really thought, is it worth doing a trabeculectomy? I can't let go because his pressures have not been coming for the past many, many months. So that is the first case that I did a GAT, and I was so happy for him that I think I have about 8 months or 9 months follow-up, and he's off medications, pressures are 16, and he just has to come and see me once in a few months. So indication for me is anybody who requires an IOP reduction with open angles and obviously not coming down with medications is an indication. So steroid-induced glaucoma, uveitic open angle glaucomas, primary open angle glaucoma, juvenile open angle glaucoma, I would actually do, unless it is an advanced glaucoma where you require a really, really low intraocular pressure. So that is one indication for me where I don't want to do a GAT. Advanced glaucoma, IOP control with 3 medications, 4 medications, I'm doing a cataract surgery, I will combine a GAT along with it. So whether it is the KDB or the GAT, we don't lose anything. In fact, when I operated this gentleman who had a previous strap that failed, so I mean, I never expected that his pressures would come down so well and he will not require a medication. I was mentally prepared to give him at least 2 topical. Anyway, I'm going to stop PG analog post-operatively. At least continue 2 anti-glaucoma medications. If pressures are controlled, I'll be happy. He is off all medications, pressures maintained at 14. So that is what, so how long, I do not know. I think we are just learning. As time goes by, we will come to know. But to me, even if it means that I have to delay surgery, I would still be all right because I haven't touched the conjunctiva. All it takes is 10 to 15 minutes of your additional time.
Okay, thank you. And I would
Can
like
I
to
ask one question, Pratik?
yeah.
Shirisha, if a patient has a previous surgeries done, like conjunctiva is not healthy, scarred, are you going to perform this surgery, and is it going to work? Because you said no, all aqueous plexus is going to be supportive in this system for the success.
Yeah, so the scarred conjunctiva, does it have a role in scarred conjunctiva? Subconjunctival vessels, I think, are still present. So when I said the outflow system, we are talking about the trabecular meshwork, Schlemm's canal, collector channels, and the aqueous veins and the lymphatics. I don't think they are scarred. It's the tissue that is scarred, the conjunctival tissue that is scarred. I don't think that's an issue. In fact, recently, a colleague of mine actually did a case post-VR surgery with a little bit of silicone oil emulsified bubbles in the superior quadrant, absolutely no conjunctiva, chosen for a TSCPC. Did a gonio to see if the angles were open, went ahead and did a GAT, and that patient was doing so well. Imagine doing a tube in this patient with conjunctiva, you're not able to close and struggling is a huge challenge. So what I'm saying is, it is a dream for all of us to be able to do a safe procedure in this complex size. So how much it works, how long it works is something that maybe next year when we have a meeting, I will tell our results. But I guess it is definitely very, very promising.
Thank you. Here I would like to involve Dr. Devan and Dr. Sirish. They are there. What is your experience with the mix, and how do you see its future in India, where it has a steep learning curve and the cost is a factor? Devan, first you take up this question.
Yeah.
Murli is also here.
I think so. Basically,
the brief because we have just limited time.
Yeah, so specialized situations or special or individual situations, as Sirisha pointed out, yes, we should keep these in mind. They are an added tool in our fight against glaucoma. But because most of the surgeries that we tend to do here will be for advanced glaucoma, there is a limitation with MIGS, and also the cost factor. So I think barring a few of them which Sirisha presented, the others are not going to be, for the masses. Sirish, what do you have to say?
Personally speaking, I had been using expressions quite before when they were introduced at that time in the beginning. Of course, now they're being used much lesser because of extrusion related things and all. What I was feeling is anything with lumen, which connects the inner part and the outer part, somehow have a high degree of unpredictability is what I felt. Of course, we have the other side, like, where we have the Ahmad glaucoma valve and shunts. But there, the difference is the tube is very, very long, and then the aqueous is pushed all the way till the mid of the globe. So you sort of over a period of time, the bleb that is formed because where the plate is, that forms something like a retainer so that there is no shallowing of AC. But otherwise, any connecting devices have a problem. But of course, the newer MIGs, we have to see. But one thing that bothers me is most of the MIG surgeries, if we see the studies, they are compared in IOP reducing capacity, not to a trabeculectomy, but to IOP reducing capacity of a plain cataract surgery. So I think probably long term something we need to see. I'm not commenting.
We just have a few seconds. Can you say something?
Yeah. Hi. So sorry for coming in late. I was stuck with another program. A very quick comment about the MIGs in India. I think as Sirish pointed out, all the other conventional standard international MIGs are too expensive for our use. We only have to modify to the extent to which we use the Prolene suture or use the bent needle kind of thing, which Arvind Pondicherry has described. I think the MIGs would definitely, I have been doing MIGs for some time now with the Prolene suture. I do find it will work to a mild to moderate extent. It will not give you very low IOPs. A lot of practical, technical difficulties are there because we've been doing traps for so many decades. We can't match the experience of that with the MIGs. We're going to take some time to adapt. But I think MIGs is the future, and there are definite indications for MIGs, and cost is going to be an issue in the Indian scenario. We have to modify ourselves to the Indian scenario and consider cost-effective options for mild to moderate glaucomas combined with cataract surgery maybe. But for advanced glaucomas, I think clearly we should not venture into MIGs, at least for now.
Thank you. So, okay, that was wonderful session. We have a limited time. I don't know, host Mayuri, you can tell us, can we go for the further discussion? Or?
No, we have to give podium to the somebody. So
okay.
Thank you, Pratik.
So thank you very much, all the speakers for wonderful talk. And unfortunately, we could not discuss about the medical management part and Dr. Manoj Mathur's talk.
All coordinator, please take over.
That's it. Can't say anything. We should have to have enough time for that. So thank you very much. Thank you all the speakers, and thank you all the panelists for your wonderful presentation and discussion. Thank you. So yes, the hall moderator, it's all yours now. You here? If you are not here, then we can carry on our discussion.
Yes.
Yes, sir. Yes, sir. We can go on with the panel discussion that we had for 15 minutes now.
How many minutes?
No, there's another session. There's another session that's going to start 11:45. So
yeah, that's right.
Yeah.
There is another session, but I don't know anyone is there.
Yeah, we are there. We are there. Dr. Ashish is there. And I see also
Ashish
Dr.
is there, and Dr. Chakrabarti is there. Yes.
Okay.
I'm so sorry. I think my schedule is a little different. So what session are we having now? Because in my schedule it shows from 11 to 12:25.
But it has been divided into two.
Yes, Shini, you take over.
It is divided into two.
Thank you so much.
Okay, bye.
Yeah, I think we have the biosimilar section now. It's being divided into two in the same thing. One is the glaucoma and next one is the biosimilar. That's what I see.
All right, sir.
Yeah.
So just your voice is a little not clear enough. Can other doctors also confirm that? Dr. Srinivas Joshi.
Yeah, that's right. Shini, your voice was not clear.
How is it now, sir?
Yeah, it's better.
It is clear, sir.
It's
Yes.
better, yeah. Go ahead.
Thank you so much, sir. Thank you. So shall we move ahead with the next this thing?
Sure. With the panel discussion, it's all yours, sir.
Yeah, thank you so much.
Yours.
Yeah, thank you, Pradeep, sir. Thank you so much. It's always nice to see you. Thank you. So now we'll start with the biosimilars. As we all know, has brought in a big change on the horizon. And our Honorable Prime Minister pressing it more for the generic drugs I think now the biosimilar age is now coming preponderously in our country. So our first speaker would be on biologics, biosimilars, and biobetter, the current and the future, by Dr. Ashish Sharma. Dr. Ashish, are you there?
Yes, Srinivas, how are you?
Yeah, I'm good. How are you?
I'm all right. Thank
Good.
you. I'm there.
And then after that, we have Dr. Devlal Chakrabarti speaking on the real world safety outcomes. And then we have Dr. Raja Narayanan, Dr. Amninder Gupta, and Dr. Saurav Sinha. Dr. Pramod Bende will be joining a little later. So I request Dr. Ashish to please go ahead with this presentation.
Sure. Just I'll read.
So any issues you're facing while sharing the screen? It is up now. Yes, sir. We can see your screen now. Request you to unmute yourself, sir.
Okay, you can hear me as well?
Yes, sir. Yeah.
Okay. Srinivas, with your permission, can I go ahead? Can you guys hear me? Can I go ahead and start?
Yes, sir. Please start.
Okay. So good afternoon, and rather than good evening, each and everyone. And I'm going to talk about the biologics, biosimilar, and biobetter, which is kind of area of interest globally. And we have been trying to understand these molecules since last 3 years. And this is our contribution in the form of publications that we had related to any biologic and the biosimilars in the last couple of years or so. So I would like to acknowledge all the faculty members and our colleagues across the globe who have been helping us to understand these molecules in the last 2 to 3 years. And I would like to especially acknowledge 2 of my residents, Dr. Nilesh Kumar and Dr. Nicola Parachuri, for helping with all these publications a lot. So I do have financials to disclose here because it's an INTAS program, and I have consultancy for INTAS. So this is the first paper that we published in 2019 March, and we asked the question that whether biologics, biosimilars, and biobetter, these different terms or are these different drugs. So essentially to say that all 3 are different entities because they go through a different kind of regulatory pathway with subtle differences. And biologics, if you just talk about the biologics, as per the EMA, which is the European Agency of Medicinal Product, it defines biologics as any medicinal product that contains biologically derived protein as an active substance is called biologic. So biologics essentially, they need to involve some kind of living organisms in their process. So that's how they are extracted. So that's where, protein differences, it exists. So if you look at the biologics, means you can find biologics in your day-to-day, scenario, clinical scenario. For example, easiest to point out is insulin. But if you really just want to talk about biologics as in the retinal practice, we have 4 molecules that we have been using since last 10 years. Avastin, Lucentis, aflibercept, and the new kid on the block is brolucizumab. At the left-hand side of the slide, if you look at, this is the classical structure of any kind of monoclonal antibody, which should have FC portion at the bottom and the FAB portion, which essentially is used for the antigen recognition. So what happens is, this is the structure which can be played upon, and that's what the companies are being doing by changing the structures. And With each change, you can have differences in terms of the molecular efficacy, even the molecular weight. For example, if you look at the Western the classical monoclonal antibody structures having all the light chains, heavy chain, Fc portion, FAB portion. But if you look at the aflibercept, it has a little bit change in the FAB portion with the decoy receptors, but Fc portion exists. However, in the other two molecules, in Lucentis and in the brolucizumab, you have absence of Fc portion. Absence of Fc portion can lead to various advantages and disadvantages. Primary function of Fc portion is to provide stability of a molecule. But as a molecule keep getting smaller in the size, you can have folding differences in different kind of molecules. So look at the different sizes of all these molecules. And the newest molecule that we have, brolucizumab, is the smallest size molecule. And the smallest size not only in ophthalmology, rather smallest size molecules have ever been made in medicine. So biosimilars, if you talk about, biosimilars are essentially molecules which are kind of similar to the biologics, which are already approved by the FDA and EMA. What they need to show is they need to show similarity in terms of safety, purity, potency. They can have they can have differences which are not clinically meaningful because they cannot be the exact copy of the biologics. Why is that? Because they do not get the entire information. Whenever they get the product, so they need to do a reverse engineering. And the example of biosimilar is Resumab, which is the biosimilar of Lucentis. If you want to see more update on what is happening on the biosimilars, you can refer this paper which was recently published. So essentially, sometimes, if you are not going deeper into the details of biosimilars, they are sometimes get confused with the generic drugs. But generic drugs are basically, if you look at the left side box, chemical formulas. However, biosimilars, they come from the living organisms. So the process of manufacturing is pretty complex as far as any biologics is concerned. However, chemical formulas, for example, ibuprofen, you must be knowing that ibuprofen, you can have many brands of ibuprofen and they can be manufactured in the common, simple facilities. Now, the question is why actually you need biosimilars? Essentially, the one benefit that biosimilar provides over the innovator molecule is the cost benefit. And how can they do that? Because reference biologic takes approximately 10 to 15 years with an investment of approximately 1,200 to 2,500 million USD for a single molecule. However, biosimilar can cut down the years up to 8 to 10 years with quite almost 1/10 of the investment that innovator biologic does. So that's why they can provide cost benefit ratio, but you cannot say that that can happen like generic drug because essentially they also need to spend a lot of money. That is why all companies cannot get into the biosimilar development. This was my question when biosimilar was approved in India, that when can biosimilar enter in a country for its use? Because my question was, if you already have the your proprietary rights, then how can you come before even a decade? So each and every regulatory works in a different way. How India works is, if any drug which is not being used in India and it is being used and shown safety and efficacy data for 4 years in any other country, you can go ahead and manufacture those drugs as a biosimilar. So this is as of now, Resumab is only approved in India. It has not yet gone outside India, and there is no biosimilar in ophthalmology, especially in the retina practice, which is approved by the FDA or EMA. And I know that Intas is trying to get approval. They are into their trial. So first candidate, what you could see in future as biosimilar or ranibizumab, which is on the verge of approval, is SB11 by the Samsung Biopsys and the Biogen collaboration. And recently, Dr. Neil Bressler, he published, he was a lead investigator for the trial. They published the data on SB11 phase 3 trial. And we had some questions in terms of, because there was discrepancy in terms of the endpoints, the primary endpoints for FDA and for the EMA. Dr. Neil Bressler had, answered all our questions, but still we had some of the communication going on with the FDA evaluator, who is going to clarify that how these two evaluating agencies are different in terms of the biosimilar approval process. You might see that paper very soon. And as I was mentioning, that biosimilars, they have a different kind of approval pathway. That's how they save money. And this was the paper, which we published, that how the various aspects of the approval pathway is different, because ophthalmology is experiencing this biosimilar as a new entity. So people, even at the higher level, are not aware about the approval process. So essentially, if you want to simplify it, these are the two pyramids. One is upside down pyramid and one is normal pyramid. So normal pyramid, at the baseline, you have to have the analytical data to show the bioequivalence, and you need very little information about the clinical trials. That's how they save money on the clinical trial, most likely, and they could pass the benefit. So entire world can take some cues from India in terms of, am I audible?
Yes, go ahead, Dr. Ashish.
Okay, so entire world can take cues from India, from the experience of India, because we are now experienced more than 6 years. And these are the couple of papers that we published, and especially I would like to highlight that education plays an important role for biosimilars, to be used effectively, because there is a lot of nocebo effect goes around these drugs because they are not copy of the innovator molecule. Biobetter are the molecules which are related and quite similar to the biologics. And what happens is sometimes some molecules, they do not perform the way they were designed. So if you want to improve upon them in terms of the safety, efficacy, and the other aspects, you can change a little bit, and you can again go them for the approval. But the problem with Biobetter is, as of now, FDA and EMA considers them as a new molecule. That is why you do not see a lot of companies, they have interest in labeling them as a Biobetter. And interesting fact, I think you would like to know that Lucentis was actually not a new drug. Lucentis was actually a Biobetter of Avastin. They have cut down the FC portion, and they have cut down the one arm, and that's how it became better, a smaller molecule, which could have penetration in the retina. And as of now, what we are seeing with brolucizumab, things are not going in the right direction with a new kind of adverse event. What we propose is Biobetter could be the future of brolucizumab. We do not know whether company would come and label it as Biobetter or as a completely separate molecule. That is the thing for future. Thank you for listening, patient hearing, and this is the teamwork from all the residents and the entire group. Thank you very much.
Thank you so much, Dr. Ashish. In fact, Ashish, if you remember in the VRSI conference when I first presented the biosimilar,
I was the strong critic.
Yeah, you were, and no, let me complete. So Dr. Ashish was such a strong critic that he was just bombarding me with the questions and the question. And I'm so happy that he has taken it so much forward. And in fact, he is the man who is now working more on biosimilars. On the contrary, when he was bombarding me with the questions in VRSI. And I still remember one of your questions, Dr. Ashish, that why this trial was not done in the rhesus monkeys. Can you then later on, of course, I told him that I'm a clinician, I'm not a scientist, and later on I got to know about that this need not be done in rhesus monkeys is because it's a biological product. If you have to do a phase 1 and phase 2 trial, that is where the bigger animals are required. Otherwise, for already approved drug for the biologics to be happening, we don't require the rhesus monkeys to be involved into the trial. So we have our panelist, Dr. Raja sir, also here. Yes, Dr. Raja sir, any comments on the beautiful presentation by Dr. Ashish?
The only beautiful comment which I can make is Ashish has done a tremendous job from India. He has been a torchbearer not for India, for the entire world in this field. Overall, I would say that biosimilars definitely have been an important addition to the world. If we cannot just be presenting in conferences, I gave 3 or 4 Lucentis or Eylea and X number of patients improved. But what happens to the 10x number of patients who are not being treated or unable to get treated? And in that context, both biosimilars, which are cost effective and also safe. In terms of safety, we definitely need to evolve more in terms of how we can make those assessments, as Ashish has also worked on it. How should FDA, what all should it look at, what parameters it should look at? And when we say FDA, right now it's US FDA, but at some point, even the Indian CDSCO, we should be able to guide them and tell, okay, these are the things which we should look at for biosimilar approvals. And if you do this, then we won't have setbacks in the future.
Actually, sir, I mean, sorry to interrupt you. What has happened, recently? If you look at the SB11 data, which trial Dr. Neil Bressler was heading. If you look at the primary endpoint, they had 2 primary endpoints. One is the BCVA, one is the CMT. And BCVA is for FDA and CMT is for EMA. So that was our question, that why these 2 regulatory agencies are differentiating. And then we wrote editorial which was rejected by the ophthalmology. And now, but in ophthalmology, we received a reply from editor-in-chief. He said, we have sent this to a person who deals with from FDA. It was rejected, but then a person who deals with FDA, because Cooperman was co-author, he called Cooperman and he said, the information was so important to clarify that I want to correct that paper. And I want to make sure that that goes in public domain. So we will know that in terms of regulatory aspect.
Good. Thank you. We have Pramod Bente sir also here. Pramod sir, are you there? Because he said he'll be coming in between. Now, quick question. We have under 2 more minutes before we go to Dr. Chakrabarti. Pramod sir is here. Sir, I have a question to all of you here. Can you see this? This was the thing which was given to me. It is called as Vizumab by Cipla. Yes. And just 2 days back, it was given to me. Now, Dr. Ashish and Dr. Narayanan and Dr. Pramod sir, please tell me, as a vitreoretinal surgeon, now which one to use, which not to use. And Ashish has said that, yeah, it is the Razumab which has the Indian authority. But this doesn't have an Indian authority, then how can they go in for this thing?
How does it not have Indian approval? It has Indian approval. Otherwise, they can't go to the market.
Yeah, they cannot go to market unless they have a drug controller's approval.
So if you know, even the drug from the Reliance Renizurel is also there. So when I was writing this American Academy paper review, I had the same question from them that, I want to include this, but unless I have some proof on paper, I cannot refer it. So then they showed me a letter from the DGCI, where DGCI has recommended that, we need this data more to give the final approval. But they started marketing it before that itself. So I think the same thing is happening with Cipla.
Sir, Pramod sir, your experience in biosimilars in SN?
Yeah, because we have, I think, a great experience, and we are limited with the Razumab Intas. Because other biosimilars slowly are coming in the market everywhere now, and this, as you said, Cipla is coming up, Samsung is coming up, Reliance Lab already in the market. They are behind us to have their thing with us. But the same thing, but as far as limited experience was with the Intas Razumab, I think experience is great. And it's equally effective with all other. Yes, we had a hiccup in between, and all of us, we all know that the toxicity, a little bit exaggerated inflammatory response. And I think they have sorted out that part very well. And I mean, now current practices, we give option to the patient, whether you would like to have Razumab, whether you like to have Accentrix or Eylea, patient chooses. Of course, Avastin was in a armamentarium as well, but because of this COVID situation and because Avastin has to be shared, right now we are not giving that option to patient because of obvious reasons. But yes, there's no bias. We let patient choose what he would like to have depending on his affordability. We are equal for everything.
Thank you, sir. Thank you so much for those kind words. I request you to please come back in 10 minutes, then we'll have more discussion. I request Raja sir also to put in some more inputs after Dr. Chakrabarty's talk. Over to Dr. Debulal Chakrabarty, please. Thank you, Pramod sir.
Thank you, and thank you, Dr. Srinivas. I'll be sharing my slides. I hope I'm audible and visible.
Yes, yes, yes.
Okay, so very good afternoon to all. I'll be speaking on our recently published study, real-world safety outcomes of intravitreal ranibizumab biosimilar, that's Razumab, therapy for chorioretinal diseases. So we have no financial disclosures, no funding was received for this study, and the article processing charges were waived by the editor on our request, as we did not have any kind of funding. So we all know that AMD, DME, and RVO are among the leading causes of vision impairment and blindness throughout the world. Aging population and the epidemic-like growth in the number of patients with metabolic syndromes are projected to increase the global prevalence of AMD from 170 million in 2014 to 288 million by 2040, and of diabetes mellitus from 415 million in 2015 to 642 million by 2040. So now, just like Dr. Ashish mentioned, we have these molecules which have, done human service in the field of retina for management of visual impairment due to neovascular AMD, DME, and RVO. And we have, apart from this, of course, the biosimilars coming in now. So to optimally treat retinal diseases, these drugs must be injected repeatedly, as we know, over many years, but the high cost of treatment regimen is a prohibitive issue, especially in our country. And this underscores the need for a widely available, economical, and effective anti-VEGF drug, which has an acceptable safety profile. Now, bevacizumab meets most of these criteria, but its use is off-label, and need for compounding increases the infection. On top of it, just like Pramod Bhende sir just mentioned, the COVID situation adds to the issue of having to give to multiple patients from the same vial. So, and at Disha, we are not using Avastin from 2014 onwards because of cluster endophthalmitis cases that we had at that point in time. So biosimilar drugs that are structurally and functionally similar to approved biologic agents are important advance in the management of retinal disorders. And Razumab, of course, was the first biosimilar, as has been mentioned, to have been approved by the Drug Controller General of India in 2015. Now, the purpose of the current study was to, it reports the ocular and the systemic safety profile from real-world usage of Razumab at our place, following large number of injections. So this multi-center collaborative retrospective chart review included patients from 15 centers, and eligible patients received Razumab injections between January 2016 and March 2020. And the study was conducted in accordance with Declaration of Helsinki and was approved by the Ethics Committee. Well, the patients with treatable chorioretinal diseases like neovascular AMD, DME, macular edema due to RVO, and as preoperative adjuncts, also Razumab was used. And these were picked up for the study. The treatment regimen varied. It could be PRN, it could be 3 monthly dosing followed by PRN, or treat and extend from baseline, or 3 monthly doses followed by TNE. So based on the retinal physician's discretion, as also the underlying diagnosis, and most importantly the patient acceptability and profile, the actually treatment schedule varied. Now, all injections are performed in operating theater under sterile techniques, as is usually done in India. And povidone iodine 5% was applied to eyes both immediately before and after each injection. After each injection, the patients are followed up on day 2 and at 1 week and at 1 month. And additionally, patients were advised to follow up immediately in case of occurrence of any ocular or systemic adverse events. Now, outcome measures, the adverse events and adverse drug reactions were subclassified as serious or non-serious. And serious adverse events or adverse drug reactions were defined as any events that resulted in death, a life-threatening adverse event, required inpatient hospitalization or prolongation of existing hospitalization, and resulted in persistent or significant disability, incapacity, or a congenital anomaly or birth defect. And events that did not fulfill these criteria were labeled as NSAE or NSADR. So moving on to the results, a total of 31,645 injections were actually given in this period. And out of these, there were 9,406 Razumab injections that were performed, or biosimilar ranibizumab injections that were performed in 6404 eyes. And they had a mean of 55 years, 53% males, 46% females, and a mean of 1.49 injections. So if you look at the list of indications, well, almost everything that needs an anti-VEGF was included: DME, BRVO, neovascular AMD, preoperative adjunct, CRVO, CNVMs, NV, and some miscellaneous cases also. So talking about adverse events, the total number of adverse events were actually 21%. That's 1978 out of 9404 injections. And the subconjunctival hemorrhage, mild ocular pain, totaling 1269. Actually, these were non-serious adverse events that were noted. And non-serious adverse drug reactions were 652, out of which transient blurring of vision in 612 eyes, that is 6.5%. Raised IOP that needed medication in 31 eyes, and mild anterior uveitis was noted. So talking about serious adverse events, the serious adverse events such as vitreous hemorrhage, hyphema, and lens injury were noted in a total of 10 eyes, which is 0.1%, and serious adverse drug reactions such as RP tears, non-infectious vitritis, and infectious endophthalmitis, these are ocular, of course, were noted in 34 eyes. And systemic non-fatal MI and non-fatal CVA were noted in a total of 13 eyes, 7 and 6 respectively. So, in this, coming to discussion, in this real-world safety study of ranibizumab biosimilar, adverse events were seen in 21%, as I have mentioned, but 97% were non-serious. And our study shows that adverse events such as those noted with Razumab were not actually, different from those described with other anti-VEGF agents. The reenact trials found that Razumab was safe and effective through week 48 in patients with neovascular AMD and RVO. And though no new safety concerns with Razumab were mentioned, the authors actually failed to address safety concerns other than IOP changes. The AO has noted a short-term elevation of IOP immediately following anti-VEGF injections, followed by a gradual normalization over a week. In our real-world series, actually 31 eyes with raised IOPs had to be managed with pressure-lowering medications. Now, in this point, I should mention that these were, of course, not the NVG eyes, were not included in this. And meta-analysis of clinical trials and real-world data report endophthalmitis rates following intravitreal injections to be 0.026 to 0.056%. Our large sample size of 9406 injections detected an endophthalmitis rate of 0.01%, which is similar to that with other anti-VEGF drugs. Now, intraocular inflammation is being talked about recently with the induction of brolucizumab and the incidence of IOI. We all know from the Hawk and Harrier trials are 4% for brolucizumab and 1% for aflibercept. We found a non-infectious vitritis rate of 0.02%, that is 2 out of 9406 with Razumab, and this is similar to what has been reported with other anti-VEGF agents, from 0.05 to 2.9%, and lower than that, that is 0.3% attributed to SB11 or SB11, that is the other biosimilar ranibizumab from Samsung that was just being spoken about by Dr. Ashish. Systemic safety of intravitreal anti-VEGFs, of course, remains an unresolved issue, and our study was not actually powered enough to look into this, and as also hardly any trials which have been powered enough to detect a relationship. The reported rates of systemic adverse events associated with intravitreal anti-VEGF therapy ranges from 0.6 to 13%. And 13 eyes, or 13 patients rather, that is 0.2% cases of non-fatal events, including 7 and 6 cases of CVA. And if this incidence were to be extra treat per patient, it would give us roughly an estimated risk of 4.8%, which would be similar to that seen with longer studies with other anti-VEGF drugs. Now, in addition to efficacy and safety, cost effectiveness is often considered important when selecting an anti-VEGF drug. And the high cost of many anti-VEGF treatment regimens limits the number of treatments that many patients can afford and often prevents a satisfactory and sustained outcome. So biosimilars that are approved by regulatory agencies could be effective, safe, and at the same time cost-effective alternatives to available therapy, especially with the current situation that we are not being able to use Avastin. Biosimilars could reduce treatment costs by 25 to 50% depending on the setup and compared to the parent biologic drug. So our study had limitations. This was, of course, a retrospective study design, and with a brief follow-up period, We lacked a control group against which a comparative analysis could have been performed, and the study did not, was not designed to look into immunogenicity. And at this point, I'd like to bring this study forward, which actually was published by Sharma et al. Recently. And they actually saw that 7 to 8% roughly of treatment of these patients who were treated in this ASSET study were positive for anti-ranibizumab antibodies. However, no adverse events suggestive of immunogenicity were noted in their study. So to conclude, in the real world setting, intravitreal razumab therapy or biosimilar ranibizumab has an acceptable ocular and systemic safety profile in the management of chorioretinal vascular diseases. I'd like to thank you all and acknowledge my team at Disha.
Thank you so much, Dr. Chakrabarti sir. That was really a wonderful presentation. Raja sir is here, and Dr. Ashish, are you there?
Yes, yes,
yeah. So since you are spearheading the movement of biosimilars in India and abroad, so now we all know that the Intas razumab has well cleared it. We knew that any biosimilar which comes into the picture, leave about biosimilar, if you take about aflibercept, that also had a teething problem. If you look into the Lucentis, that also had a teething problem. So any new products in the initially will have these teething problems, right? So what should the general ophthalmologist or a vitreoretinal surgeon looking for? Because in the initial period, many of these injections are showing sterile inflammation. So which one to choose, which not to choose, how should they go upon it? You and then followed by Dr. Raja sir.
So I think, now the gold standard is pretty high. So anything which comes new will always be compared with what we have in, existing. So until unless you have mild IOIs, nobody minds it. But, the main thing that we are seeing with brolucizumab, the brolucizumab has taught us that rather than just seeing the mild IOI, try to look at the periphery, because that's what happened with Hawk and Harrier. It was missed. So it means in anything which comes new, I would be a little more careful in my examination and in terms of, that examining pre-op and the post-op and go slow rather than going fast.
Raja sir, coming to your question, sir, many of these samples are coming. In fact, we are seeing the biosimilar Avastin also being available nowadays, and they are approved by the Indian government. So is there any recommendation which VRSI can give? Yes, this is safe to use, or how should the surgeon or a vitreoretinal surgeon decide? Because many such companies are coming up which are getting an Indian approval.
Yeah, so there are two different aspects, one is the government approval, and by law, I think it's an independent process of the government. They have their committees, subject matter experts. They evaluate. They can take the inputs from different societies if they want. But once a drug is approved, there may be some guidelines which may have to be released from the society perspective. And those are the places, indications or kind of usage protocols, what kind of treatment frequency, and what to look out if there is an inflammation, like for brolucizumab, how to manage those kind of inflammation. Those can be given as guidelines post approval, but pre approval, it's in the domain of the government. But if they ask, I would say that then there has to be uniform process, not just for retina procedures or anything. They can come to any society for guidance before they go for approval. But again, I don't know, this is repeatedly coming again and again, that Cipla or Reliance, their products are not approved. That would be illegal. So I don't know. I don't want to comment on it, whether they have or they don't. I'm assuming they have the approval, and that's why they are in the market.
Okay. Thank you, sir, for that, making it clear. Dr. Debulal, sir, you have any comments to make?
Well, actually, the issue with other biosimilars are, it's very difficult for any society, I guess, or the government to control, because these, the people who are marketing, they just come and hand over. In fact, yesterday I had a couple of people from different companies coming and asking me to, use their products. I said, no, this is not how it works in Disha. We have a, approval committee which approves a drug after having seen the DCGI permission. And that's what happened with razumab also. Initially, we were quite, skeptical about, if I can use that word, about using this biosimilar ranibizumab when it came. And initially, of course, we did a pilot trial of around 30, vials, and then we actually offered it to all the patients who actually come. Yeah, I think a protocol has to be there from the hospital or the individual practitioner concerned, and we should not be jumping the gun, because our primary duty as a physician is to help the patient. If not possible to cure the patient, at least we should do no harm to the patient.
Thank you, Debulal sir. One question to Dr. Ashish. We are now hearing the biosimilar about aflibercept as well. So how is it going? Where is the future of the biosimilar going? In few quick comments.
Means aflibercept biosimilar has led a long time, because aflibercept had patents on various aspects of means manufacturing process. So they keep on delaying. So I won't expect aflibercept coming in before 2027. So but anyway, I think so anything which comes up, we have to take in the same way, little more cautious.
Okay. Last comments, Raja sir, about the Zib aflibercept. Because aflibercept is 45,000. It is pretty expensive for the tier 2 and tier 3 cities. So of course, Roluzumab is coming up, but they have their own teething problems, and it's now coming up. But what do you suggest, sir? Zib aflibercept would be the choice for the patients who are not affordable, who are not responding to Lucentis, Raja sir?
Yeah, see, first of all, Zib aflibercept is not a biosimilar. It was a molecule which they had prepared already with a different osmolar concentration. But overall, I would say the Zib aflibercept, which we use intraocularly for the same volume, 0.05 ml, it is only 1.25 milligram, whereas aflibercept inject inside is 2 milligram. So you cannot equate or equally compare it with apples to apples. But in case you are getting inadequate response with some drug and you want to give aflibercept as a switch, Zib aflibercept is an option. But even there, if sometimes it's not coming with the 0.05 ml of volume which you are inject, you can give 0.08 ml to make it 2 milligram and try giving those. But overall, India is the bread and butter of our biosimilars. So many biosimilars are now available in India, but the regulatory process has to be strengthened, and real world data has to also be used. And that's what I think what Ashish mentioned, that DCJ is asking for more data. They usually give this kind of letter for all approvals. We will need more data. The interpretation is okay. You can go to the market. Now you are legally, but they will ask for more data.
So thank you so much. Thank you, Ashish, for the wonderful presentation, and looking forward to more such because it's now the need of the hour. The biosimilars are going to be the need of the hour. There's so much of unmet need in our country, and so much of people below the poverty line. I think that's going to be the future. Thank you so much for your lucid presentation. Thank you, Dr. Debulal sir, for sharing your experience as well. And as always, Raja sir, very lucid and crisp in his comments. Thank you very much, everyone.
Thank you all. Bye. Take care.
Thank you, everyone, for such a